Okay, I think we're going to move it over to questions now from the audience. And we have some folks from Pfizer who are walking around with microphones. Cyril.
My question is really more from a provider's perspective, and it's probably confusion in my mind. I'm worried about the number of, say, neighborhood health centers like one that's represented here, and rural ones, and separate organizations like VNS and GMHC, and other kinds of health care provisions which are funded by other sections of the federal government. Are they favored or taken care of, or is it assumed that they will survive along with the Affordable Care Act? Because one would be very, very taken aback, if something like Ryan White suddenly was not available to us or to the country.
This is a great question. This is a fundamental shift. This is the fundamental shift in health policy for the United States. We have had a program where healthcare delivery has been defined by if you have a job, a good paying job, you get health insurance. And the poor will be on public programs or grant funded services. Now we are moving everyone into the insurance model. And the insurance model, is, and rightfully so, is anticipated to be comprehensive. One of the things that I can say for our health center is I do get AIDS funds, but I also get family planning funds for youth. I get substance abuse funds and mental health funds. And what's been very clear is, our folks have said, you may not get those funds next year, or those may be reduced because we expect the health insurers to cover these things. And I think you're seeing organizations and community providers, but also hospitals here in New York City, are really consolidating and shoring themselves up for what is, potentially less reimbursement and fewer subsidies as we move people into a managed care marketplace. And I will also say that managed care they set prices based on an average. So it may be that, a private doctor's office is paid the same amount as a community health center, is paid as much as a hospital, and the carrying costs are very different. This is a little maybe esoteric for the audience, but I do think that but going back for consumers, it's really important to go back to your provider and say, what are you going to take? Mm-hmm. Because I can tell you, Callenwood will not take all of the plans being offered through the exchange.
What does it do to your concept and Ryan White, for example, of having this open door policy?
Well, it's partly open door, and it's partly what I've seen, what these health plans are going to pay us under the exchange, and some of them I just can't afford to take the plan.
But I think I think a couple things. First of all, I don't think anything is going to change. Things are going to change, but not significantly in the first year, and because most of these programs are continuing. So one of the programs that's out there is something called DISH, which is disproportionate share funding, and basically it's the money that the federal government sends to hospitals in poor neighborhoods because they don't have people covered by Oxford, right? In poor neighborhoods, they have more people covered by Medicaid. They have a higher charity care load. So it's basically saying to hospitals, here's some money from the federal government to keep your doors open. Well, as you can imagine, as more and more people become insured, the federal government wants to start ratcheting that DISH money down. It's like, hey, even you hospitals in poor neighborhoods, you're going to have people with insurance now, as the take-up rate. So over the course of the next, 5-10 years, those payments get ratcheted down. Now, the Health and Hospitals Corporation here in New York and other publicly funded hospitals and other hospitals that might even be privately owned but are in poor areas are very concerned about the calibration, that the way that will be phased in, And so we have yet to see whether or not some of these drawdowns are appropriate. Mm-hmm. And, globally, if they're right and if they're appropriate. And then each provider is going to be making a decision about, like, okay, now that we can't do this anymore, or we're not getting this money, we can't do this, or we can't serve this group of people, they'll have to be served over here. So I think once that's, some of those things will be happening in 2014. Some of those things are happening already.
Yeah.
But some of those things will be happening in 2014, some of them in 2015, and then as you'll see, I think a real transformation over the course of the next decade, and not only based upon this, but also based upon a number of delivery system things. You know, this idea of seamlessness and integration is really in the forefront right now. And, you know, I doubt very much that you'll see a standalone hospital ever again. You know, you'll never see, you know, high town hospital except in very rural areas. But even then, they'll have some sort of telemedicine agreement, and they'll be connected with the home health care agencies in their area, et cetera. And that's a good thing overall, you know, that integration of care. So I think there's a lot yet to be figured out, but I mean, I think some of it will be gradual. And I do think, you know, the number one advice is, if you're on a program, or you're going to a particular provider, to be in touch with them about how they're, you know, realigning, or how, whether or not that's still the best place for you.
Yeah, I'd say, you know, we've offered, well, my coworkers will tell you, you know, like, pessimist is in my job description. But I do feel like I owe the group, especially for coming out tonight, some good news. So I'll look through kind of in a past life I was a political consultant, and what I would offer is, it's my bet that given a very competitive political landscape and an election coming up in 2014, that you will probably see every step taken to reduce the amount of disruption that caregivers, be it hospitals, be it small, be it large, be it integrated systems, be it community organizations. That's not to say that it's not going to happen, but I would say is I think you have almost every political incentive to forestall as much of that volatility for as long as possible. And I think that you can kind of see that trend with some of the debates that have occurred, not just with DISH, but with also Medicare Advantage and the doc fix. You know, historically, the last thing that voters want cut is health care. Over and over, voters vote for more health care spending to the exclusion of almost every other type of spending, and I think that should give us some degree of comfort looking ahead.
I think that's right.
Hi, do each of the different tiers, like from bronze to platinum, do they each have like hundreds of different plans within the tiers? And are there in versus out of network within those tiers? And then are there deductibles?
Sure. So each tier has different deductible amounts, different co-insurance amounts. So they're different in that way. In the tier, in the bronze tier, for example, or the silver tier, the plans have to be standardized. So there might be slight differences between plans, particularly, well, there are big differences between networks, for example. Although, you know, typically, you know, if you're on Long Island, if North Shore isn't in the network, you know, I wouldn't, maybe you don't choose that plan. But, you know, I mean, so they'll probably all have North Shore in there, you know. But in any case, you'll want to look at that. But the actual benefit package itself is going to be very similar between all the bronze plans, different with the silver plans, although the essential benefits, and there's a list of essential benefits, are going to be the same in all the tiers. The main difference between the tiers is you have higher levels of cost sharing. So if, you know, as you can imagine, the bronze plan isn't as generous or doesn't cover as much as the platinum plan. Right? If you were, you know, really sick, or you're really risk averse, or you really want the economic security of insurance and you want to pay a higher premium in case you do get ill or you are ill, the platinum plan is going to give you a higher percentage of coverage, but it's going to cover similar benefits from the bronze plan. Okay? So there's real standardization there. And that's the whole point of being able to compare apples to apples, you know, amongst the tiers, but also amongst the plans. So the competition, if you will, on plans, between plans is going to be at price, because they're going to want to come in at a lower price. And some of the ways that they're going to do that is either the efficiencies, et cetera, but primarily is going to be the network that they have. So somebody might have a really bad network, and that's why they're cheap. So you have to check that out. Or they could be really cheap because they feel they're going to really manage disease really well, and there's a variety of differences between plans. But the primary difference, if you will, is not going to be in levels of coverage or buckets of coverage. That's going to be very standardized. In versus out of network. I'm trying to remember if they're going to have in and out of network.
Yes.
Yes. Yeah.
Your old buddy Margaret Davis is giving us
thank
the
you,
thumbs up.
Margaret. Yeah, they are going to have in and out of network. Yeah. Yes. Right. Yeah, I mean, one of the protections, or one of the financial protections for folks in these plans is that there's an out-of-pocket maximum. So once you spend X amount, you are covered 100%. You have no more cost sharing. Okay, and that fluctuates depending, once again, on the bronze plan, the silver plan, the platinum plan. There's different levels there. And if you're interested in kind of all these numbers, and there are a lot of numbers, I've got my little cheat sheet here, once again, from Kaiser Family Foundation. Even though I teach a course on this, these numbers, they are very, specific. And so, but generally, the bronze plan is going to cover about 60% of your health care costs. And the platinum plan is going to cover about 90% of your health care costs. Okay? So once again, you're always going to have some out-of-pocket, depending on the plan. Now, if you're poor, and like say you're at between 138 and 200% of federal poverty, you're going to get not only a subsidy to help pay your premium, you're going to get a subsidy to help pay your your cost sharing is going to be ratcheted down too. Okay, so the value of that plan, if you're in that range, could be up to 94%. So you're really only paying about 6% out between premium and cost sharing. So it sounds very complicated. It is really complicated, but it's going to be on the back end. You're not going to see a lot of that subsidy if you're in that subsidized category, because it's all going to be occurring, in some computer, that's not left over from East Germany, like our current Medicaid and other, insurance computers. It's going to be brand spanking new, and hopefully it'll work.
Yeah.
There's an article in the New Republic this week about, or month or whatever that comes out, about like what the 5 nightmares are of the ACA implementation, and one of them is the computers don't work. And so every state, the federal exchange is going crazy right now trying to get these systems up and running, because literally what they're hoping is it's as easy as typing it all in. The Department of Homeland Security talks to IRS, talks to Social Security, all behind the scenes in this data information sharing hub. And we got our fingers crossed.
But I think I would just be clear that I think it's unclear whether out-of-network would count towards your out-of-pocket cost limits. So if you're someone, in what we see for many of our consumers, is they go to mental health out-of-network. That may not count to your out-of-pocket cost. It may not be part of the subsidy. Again, it's really important to ask your providers, are you in the network? Do you accept these plans? Because that's really going to be guiding a lot of your decision making.
But there would still be coverage out of network.
It's unclear right now whether it would or not.
So you may not even get coverage.
I think you will. I think there will be out of network coverage, but it's unclear to me whether or not it will be included in your maximum out of pocket expense. You may really be then just paying full freight at a certain point. I don't know, but
Margaret, do you know? I don't know about I frankly don't know about out of network. So I think it's a question that we need to look into, and we could certainly get that for folks. But it's not something that I'm have a lot of facility with right now. So I'd hate to say yay or nay on that.
Before we get to the other questions in the room, I think we have a question on the phone.
And that question comes from the line of Araya Alexander. Hi, this is a related question about network adequacy, and I think a few folks in the room have mentioned that there are open questions as to how cost sharing might be applied in network versus out of network. Mm-hmm. My question, I think this is more a question for Jay, is around network adequacy and the designated aid centers in New York City. Right now, one of the open questions, one of the many open questions at the commissioner's level is whether qualified health plans are going to have to contract with DACs in order to demonstrate capacity in HIV/AIDS care. And if you're familiar with the HIV/AIDS care system outside of New York City, there are no DACs. So is that something that you have engaged the Department of Insurance in New York?
So,
for any of the panelists?
So the question is really about, are certain providers going to be mandated to be in these new health plans? And New York State, for a long time, has mandated networks by having certain essential providers in them. One of these has been for the Medicaid program for a very long time, are hospitals that are designated AIDS centers. They meet a separate designation of being able to provide HIV care. That network requirement was really only to have one designated AIDS center in their network. So it is not clear to me that on the commercial side, which is what the qualified health plans would be under, whether or not being a designated AIDS provider or a designated AIDS center hospital would be a requirement. In New York City, there are 26 designated AIDS center hospitals. It is almost impossible not to have a plan that would not include many of these hospitals. In upstate New York, it's really unclear whether or not those providers would be in these plans or not. But I will say that in terms of HIV, one of the things that we're seeing more and more of is plans specifically contracting with individual doctors who meet a national designation as an HIV specialist. And again, I would look for, if someone is in care with an HIV specialist or has HIV care, asking them who their provider is, what networks they're going to join will be extremely important. But also looking at, when you're looking at a plan or you're trying to help someone pick a choice, look and see in the provider directory whether or not they list out HIV specialists separately. At the New York State Department of Health, that is a requirement for Medicaid plans, and it certainly may be one for New York State for qualified health plans throughout the state.
We have time for one more question.
What was not mentioned was pre-existing conditions. If you have somebody who has pre-existing conditions, will that be covered? Is that definitely going to stay? Okay. The other question I have is enrollment periods. Before they started this a few years ago, you could change plans whenever you wanted. You'd send a letter every 30 days and so forth. Is this open enrollment plan going to remain in place, or are they going to go back to you can change whenever you want?
Change plans in Medicaid or Medicare?
In Medicare.
In Medicare.
In Medicare, so in the exchange, for under 65 and over 65, certainly pre-existing condition is gone. There's no refusal.
So they can't refuse.
They can't refuse you, and they've got to take you on, and there's a certain level that they can rate for, sex and age and tobacco use, and that's it. They can't charge you more if you have certain illness or whatever. So that's all done. In Medicare and in the exchanges, you will have this fall open enrollment period for a plan that will begin January 1st, and then under very limited circumstances, you will have the ability to change that plan within the year. But usually, you have to keep that plan for a year. So those circumstances include, you move out of the service area of that plan, or that plan goes bankrupt, or there are other malfeasance that the plan could, bad things the plan could do. But generally speaking, you're locked into that plan for that year. Okay, and so it's important. That's why it's important to make this decision, wisely, of course. In the Medicare program, you do have one chance to kind of get out of a Medicare Advantage plan and go back to Medicare in January and February of every year. But that's a tight window, and most people, only do it because they've been, they were subject to some sort of marketing fraud or, otherwise really didn't understand. So, but the general rule of thumb that we should, recall is that, the choice you're making in the fall is important. Not unlike an employer, when you're working an employer, you have to choose a plan. You're making a choice for that year. And so, you need to keep that in mind. And if you miss that open enrollment period, you can't enroll until the next open enrollment period.
Stay with what you want.
That's right. Well, and also if you don't do anything. So if you decide to go bare, if you're under 65, and this fall, and the open enrollment period is actually running through
goes into
March,
this, yeah,
March 15th, right? Or is it March 31st? I think it's through March. Then if you don't do anything, you can't all of a sudden April 15th say, oh, I want to enroll in something. You've got to wait. So it's important to act in this open enrollment period. The same in Medicare. If you are in Medicare and you want to change plans, you can't wake up on December 8th and say, hey, I want to change plans, I forgot. No, it's too late. You're locked into whatever you're in at that point for the following year.
If I may, I have just one more question. It's about eligibility for Medicaid and assets. If I heard correctly, if you're making $12,000 or less and you're in the 138%, et cetera, they do not assess your assets with that? In other words, it's on a yearly basis how much you actually earn? Or do they check your assets, and if you make more than 12, you have saved up some money, let's say, or whatever.
So, yeah.
Does that come into play if you decide you want to go into Medicaid, or it has nothing to do with it anymore?
Well, it depends on where you're at age-wise. If you're under 65 and you want to be in Medicaid, you're under 138% of federal poverty,
right.
They do not look at your assets. If you are over age 65 and eligible for Medicare, or not, you're there. It doesn't matter whether you're eligible for Medicare or not. If you're over age 65, they're going to use a different eligibility level for you. It's 100% of federal poverty, and they are going to look at your assets. So that's what I was talking about earlier. There's basically now there were 50 Medicaid programs. There's still going to be a number of them depending on the states, but generally speaking, and in New York this is the case, and any states that are doing the Medicaid expansion, they're going to have Medicaid up to 138% for people under age 65, and Medicaid up to 100% of federal poverty for people over age 65, and they're going to look at your assets if you're over age 65, but not if you're under age 65. Okay? So it's kind of like the way to think about it, if you know anything about the Medicaid program, is it's not changing for people over age 65, the eligibility and all of that. And the same with people with disabilities that are under age 65 and on Medicare. It's the old Medicaid program. And so that's, so it's not any easier to get long-term care. It's not any easier to get Medicaid if you are eligible for Medicare under, through the Affordable Care Act. The other thing that we didn't mention, if you are eligible for both Medicare and Medicaid, it's called being dual eligible, there's a lot of change coming forward, and that's the subject of a whole other panel. Some of it's occurring now, but most of that will occur, probably in 2015. But there'll be new plans that are available for folks that are eligible for both of them that should be able to coordinate care and have cheaper costs for folks. Whether that'll be true or not, we'll get there. We'll know more when we know what these plans look like, but there is some change headed that way.
Thank you.
Sure.
I want to thank Pfizer for providing this beautiful space for us and the lovely reception, which is right outside and to follow. And I really want to thank, and please join me in thanking our fantastic panelists who are really great.